Hello, today I'm going to talk about basal cell carcinoma, one of the most commonly encountered entity in derm path. There are different subtypes or variants of BCC, with the most common being nodular BCC and superficial BCC. Those three in the middle, highlighted in red, are considered high-risk variants, which include micronodular BCC, infiltrating BCC, and basal squamous carcinoma. Also, we have sclerosing amorphic BCC, BCC with adnexal differentiation, and fibroepithelial BCC of Pincus. Clinically, basal cell carcinoma are characterized by prickly papule or nodule that is present in the head and neck region, and on dermoscopy, image on the right shows telangiectasia, which is branching or dilated capillaries or blood vessels. Microscopically, BCC is characterized by islands of basaloid cells with peripheral palisading, seen here, with retraction spaces. Some keratinization can be identified in the central portion, and also dystrophic calcification may also be seen. Image on the top right is showing some nodules or islands of basaloid cells with cystic changes in the middle. This is an adenoid variant of BCC, which closely mimics adenoid cystic carcinoma and adnexal neoplasm. The bottom image is showing these nodules with cystic changes, very dilated areas in the middle. So this is another variant known as the nodular cystic variant of BCC. This is another common variant of BCC, also known as superficial BCC, which is characterized by epidermal connection into the papillary dermis. This is a high-risk variant of BCC, also known as the micronodular BCC. This is characterized by nest that is small that often extends deeply into the dermis. Clinically, they have very poorly defined border and usually flat or erythematous patches or macule. And because of this nature, they have high tendency to recur after surgical excision. Similar image showing micronodular variant of BCC. This is an infiltrating BCC, which is characterized by this narrow course of tumor cells or basaloid cells with very infiltrative growth pattern. This is another image showing a high-risk variant known as the basal squamous carcinoma, which is characterized by two highly atypical components, the basaloid strands admixed with this highly atypical squamous cells. This is showing a scar-like plaque on a patient on the temple, and this is a sclerosing amorphic form of basal cell carcinoma, which is characterized by thin cords of basaloid cells and surrounded by this very abundant stroma, collagenous stroma. The differential diagnosis for this entity include desmoplastic trichoepithelioma and microcystic adnexal carcinoma. One is benign and the latter is malignant. Coming up next is a BCC variant with adnexal differentiation, and as you can see here, this is showing some infundibular or follicular change. So this is BCC infundibulocystic type. This is another BCC showing sebaceous differentiation, which is characterized by this basaloid cells admixed with multivacuolated mature sebocytes, and this entity is seen in a syndrome known as Muir-Torre syndrome, and they actually can show some overlap histologically with other sebaceous neoplasm. Another BCC with adnexal differentiation, and in this case, you see this islands of shadow cells indicative of hair matrix differentiation. So this is a BCC with matrical differentiation. Last but not least is the fibroepithelioma of Pincus, which is another basal cell carcinoma variant showing this delicate anastomosing strand of basal-like cells with abundant fibroblastic stroma. They are more commonly occur in the trunk and back rather than on the head and neck region. And here is a short presentation on the different variants of basal cell carcinoma.